nearly 200 countries by age and sex from 1990 onwards. So that goes to say the how extensive the work is. And one of the important features of GBD work is that it is continuously updated based on the new data availability. Now that could be a problem to some if you are trying to figure out the trends, because the things do change when you get new data, but that's how it works. This slide very quickly, this slide summarizes the GBD methods in terms of what it does. I will not get into these details today, given that I have 40 minutes to present the data that I have today. But happy to discuss this further in person with anyone or over another Zoom call for those who are interested. What is India's state level disease burden initiative? Now this we launched in October 2015, which is a joint effort between Indian Council of Medical Research, Public Health Foundation of India, and IHME based at University of Washington, in collaboration with the Ministry of Health and Family Welfare. We have 16 now, the disease burden groups that are listed on the right. We have 300 collaborators from over 100 institutions in India. So basically the idea is that all of us have done enough work in our fields in various capacities, but this initiative brings all of that together as a common knowledge to understand what's happening in India with various diseases, risk factors, and causes of death, and see how to move forward together. Okay, now we understand, we've been talked, all of us for many years talked about the national estimates. But over the many years, we also realized that the national estimates mask the local variation. Local variation at the first cut would be a state level variation. So for example, if the neonatal mortality rate for India in 2017 was 23.5, this hides the fact that it actually ranges in Kerala from 7.1 to 31.7 in Uttar Pradesh. So the map on the right is the neonatal mortality rate in 2017 by state. So the more red the graph looks, the higher the rate. That's true for most of the maps that you would see across this presentation. So clearly, this shows the importance of moving from national level estimates to state level estimates. Now, given, as was sent in the opening remarks, in India, the districts are as large as certain countries. So clearly, if you have a state estimate down from national estimate, that may not suffice the action that you actually need at that local district level to make a difference. With this background, we have now estimated child mortality for each district in India to understand where each district is and how we need to move forward in those districts, and compared it to move forward towards the SDG goals and the Indian national child mortality goals. Analysis overview. Today I will present the under 5 mortality rates and the neonatal mortality rates from 2000 to 2017. First for the states, but then a quick review for the states, and then for 723 districts of India. Trends of these rates over time, and then projection of these rates for 2025 goals for Indian government and for SDG 2030. We also looked at the inequality of these rates between the districts to understand how certain districts have moved and certain districts have not moved over time, to understand those differences better. The states throughout the presentation, as we do with the GBD India presentations and papers, are divided into 3 categories based on socio-demographic index as low, middle, and high. And SDI is basically an indicator of the per capita income, mean education years, and the fertility rate. So typically in India, you would expect in the low SDI, Bihar, Rajasthan, UP, all those kind of states fall in low, and in Kerala, Tamil Nadu typically fall in high. For the data that got used for this analysis was the birth history data, which is available at district level from the large national household surveys, and using complete birth histories and summary birth histories when available using indirect methods, and cause of death from these sources. And all these details are available in the appendix that we have published. So I'm happy to discuss the details whenever needed. I mean, those are quite detailed appendices. Happy to discuss in another call with those who are interested. But the data were extracted at the lowest level possible with reference to the global positioning system wherever it was available. For example, NFHS4, as we know, did have the GPS documentation. And wherever it was absent, we marked it to the closest district that was possible. Results. What did we actually find? This graph shows the number of deaths from 2000 to 2015, the under 5 deaths and the neonatal deaths. Clearly, as you can see, the numbers have dropped. Still a lot, but the drop is very impressive, with about 1.4 million deaths, under 5 deaths in 2017, and close to 0.60 million deaths, neonatal deaths in 2017. This is how the rates have changed. The under 5 mortality rate dropped from 83 to 42 over these years from 2000 to 2015. So just give me a minute. I'm trying to minimize the video screen so I can see my slides completely. Yeah, that would be good. Thank you. And this is the NMR rate that's moved from 38 down to 23.5. And clearly very impressive reductions in both of these rates from 2000 to 2017. This is how the map looks by state for under 5 mortality and neonatal mortality. This is the India rate. But then, as I said, the more red it is, the higher the rate. So as expected, the places, the states where you see more red in under 5 mortality, you also see that red in neonatal mortality. But there are certain differences which are very obvious even in this map. This is the ratio of neonatal mortality to under 5 mortality. For India, that's around 0.55, which is more or less similar across the states. But as you notice, certain states, the northeastern states, have it slightly lower than the other states in India. This graph shows for all the neonatal deaths that we have, what proportion of those are early neonatal deaths, which is deaths between 0 to 6 days, and late is 7 days onwards. So far, for all the states put together, this is each bar is a state. India still has the most proportion of deaths still are within 0 to 6 days. So we are still struggling a lot with the early neonatal deaths, which has implications for what we continue to do to bring the mortality rate down. Variations across the state. In terms of the deaths, for example, it varies from the highest number of deaths were 0.31 million in UP, no guesses there. And the least were at state level were 180, and this is a 95% confidence interval in Sikkim. So clearly there is the extent of variation at state level in India is fairly huge. This is the extent of variation for the rate. For under 5 mortality, it ranged 6 times, from nearly 60 in UP to 10.4 in Kerala for under 5 mortality, and 4.5 times again from UP and Kerala, from 32 to 7. Annual rate of change also had a variation. The average was close to 4% for India and 3% for neonatal mortality for India. But as you see, again, there is a range here even by the state. What does this all mean for our targets? the National Health Policy 2025 target for under 5 is 23 under 5 deaths, and the SDG 2030 target for under 5 is 25. So what these, so this is a 2017 map. This is the map for 2025 projected rates, and this is for 2030. Now, it's important to remember that the projections for 2025 and 2030 are then assuming that the trends that we have seen from 2000 to 2017 were to continue. And if these continue, this is what it's likely to look like. But as many of us know, with COVID in our midst now, we really don't know how good these maps are likely to look once we are done dealing with COVID. But it's important to know that these are the India rates, that in 2025, India is going to miss the national health policy target, which is 23. And you can see the states here, which are likely to miss. And India will also miss the SDG 2030 sorry, India will reach the SDG 2030 target, but will miss the NHP target. The gaps, this shows the gap between the 2025 rate and the 2030 rate by the states. So for 2025 target, these are the states that are going to have a much larger gap from the target. So basically indicating that these are the states where we need much more attention if we have to reach the 2025 under 5 mortality target. A similar projection for neonatal mortality rates at the state level for 2025 and 2030. We will miss most likely the 2025 target and the 2030 target, but please do look at the 95% confidence intervals. They're fairly wide. So from the point estimate, we might miss, but again, these are based on the trends that we know. But if things were to change, these numbers could look very different. District level. This is how the under 5 mortality rate looks when you look at India's districts. These are 723 districts. This is how the map looked in 2000. And this is how the map looked in 2017. So clearly the drop in that you saw in the rates is reflected at that district level. The redness of the map has really reduced down to when you see the 2017 map. But what's interesting is the extent of district level variation is way more than what we found for the state level. For under 5 mortality for districts, there was a 10 times variation from nearly 90, the rate of 90 in Budhan in UP to 8.4 in Thrissur district in Kerala. So clearly the extent of variation has gone up as we have gone down at a more granular local level. Under 5 mortality for tier more was mostly seen in the less developed states, and that's not a surprise because that's where we do have the largest chunk of burden. This is the annual rate of change from 2010 to 2017. The colors show the districts. The red one is the districts in low SDI. The yellow one is in the middle, and the purple one is in the high districts. So again, there was a range of the annual rate of change itself from no significant change down to change by 9%. When you look at districts specifically. But when you look at the districts as a group within the SDI of the states, the change was nearly, the median of the change was nearly similar. This is the inequity, which is the variation of the rates within the districts of a given state. And the inequality within the state by this coefficient of variation again ranged 11-fold. And the inequality basically has increased across the districts over time, and which is a good thing. And I'll come to that later. But this is what it is from 2000 to 2017. Similar results for neonatal mortality rate. The redness of the map in 2000 at district level has changed significantly in 2017. And as expected, the higher range at district level, 8 times variation from 46 down to 6. And as expected again, the less developed states, the states in the low SDI, still have it much more red than the other states. The annual rate of change ranged again from no significant change to about 8%, with nearly similar to slightly higher, lower here, but overall nearly similar median of change if you go by the districts, by the SDI of the state. Inequality again has increased by about 13-fold for NMR by the districts within a given state. Just to put it all together, like I did for the states, again, the deaths varied from nearly 11,000 deaths to 1. I think this was Lakshadweep. The rate ranged, as I already mentioned, nearly 11 times and 8 times, again in UP and Kerala. And the rate of change also ranged from 9% to no change to 8% to no change. So again, clearly the extent of variation as we go down has gone up. This is how the district map looks when you project it for NHP 2025 and SDG 2030 targets. This is the 2025 under 5. This is 2030 under 5. This is NMR for 2025 and 2030. So clearly we know which districts need more attention. And if you look at in terms of numbers, 455 of the 723 districts, which is about 63%, would need a higher rate of change if these were to reach the 2025 target. But for SDG target, it's about 34% of them. Nearly 50% for NMR and 60% in 2025 and 60% for NMR in 2030, which is the rate of change that I've shown you in a previous slide. So that annual rate of change needs to go up if we do need to attempt to get to these targets. We also then went ahead and tried to identify priority districts. We did this for states which had 20 or more districts, about 18 of them. And we divided this, we did this by tertiles. So of the under 5 mortality rate and neonatal mortality rate, and also tertiles of the annual rate of reductions. So these were categorized as high, medium, low. And so were these categorized. And then we said, which ones are likely to be priority districts? And this one can do the way whatever you think, how you want to define priority, but this is how we defined. We said that the districts which are currently having high rate and a medium rate of change, and high rate with a low rate of change probably need attention, because the rate of change is on the lower side and the rate is on the higher side. And then we said, okay, there are also districts with medium rate at this time, but the rate of change of the reduction is really low. So these, if this low rate continues, these could easily fall into the higher category. So we picked up these 3 groups and said, okay, let's look at the districts to see which these districts are likely to be. And this map is for under 5. These are the priority districts that we've identified. These are the groupings. So there are a high rate and low rate of change, high current rate, mortality rate, and high rate of change. So there is that permutation combination available for you to see. And I will give you an example of a state here. So if this is the UP map. So as you can see, if you see the high rate and low rate of change is the orange one. So very clearly, these districts in UP, these ones here on the orange, clearly need more attention at this point than UP as a whole. And this is the value add of this work down to the district level. So as you can, and the variety again, even in UP, which is one of the states with really high burden, but you see there are enough blues, which is the low rate and medium rate of change, and low rate and high rate of change. So there are blue districts even within UP, and so that's an important understanding to have. Similarly, we identified a priority districts for neonatal mortality rate. And here I take example of Bihar to convey this point. So these orange ones are the districts in Bihar that need much more attention currently. If the NMR in Bihar needs to go down further and quicker, and the blue ones here, see the number of blue districts is fairly decent even in Bihar. Causes of death. This data for causes of death and risk factors was available only at state level. We do not have this detail available in India yet at district level. This graph is very busy, but it shows change from 2000 to 2017 in under 5 deaths, and the other one in neonatal deaths. But I have summarized it here for you for 2017. This is the current structure of causes of death under 5 deaths, and this is for neonatal deaths. And clearly, we know the ones that are shown in green. So LRI here, diarrhea here, and measles here. These are the causes of death that have actually gone down, have gone down a lot as compared with 2000. So diarrhea, for example, has gone down by 70%. Measles have gone down by 80%, and LRI by 60%. So clearly showing that we've done well in addressing certain causes of death. But clearly, there are other causes of death that are coming up, or certain causes of death that we really haven't done as well to address yet. And preterm birth and birth asphyxia here clearly link very well with the distribution of neonatal deaths. In one of the earlier slides, I've shown that about 80% of neonatal deaths are within 0 to 6 days. And actually, most of them are within those 0 to 2 days. So clearly, these causes of death continue to need more attention if we need to reduce the neonatal deaths in that early period. Risk factors for child mortality. These are the 2000 risk factors, and these are for 2017. This is under 5, and this is neonatal death. Again, 2000 here and 2017 here. So one look at this graph, it's very clear that malnutrition is clearly driving a big driver of child mortality. And I think it fits very well with the UNICEF agenda, focusing also on nutrition. And it continues to be, it was in 2000, and it continues to be the largest contributor as risk factor even in 2017. The unsafe water and sanitation accounts for the next, followed by air pollution. With this paper that got published, there was another companion paper that on child growth failure that was published in eClinical Medicine, which has also very detailed data on district level undernutrition, stunting, and wasting data. Right. So what does all of this actually mean? Just to put all of this together in one slide, what it means is that we know, and I've taken under 5 mortality as an example here. We know what it looks like by state now in 2017. We also now with these data know how it looks like at the district level in 2017, the most granular that we can get at this point in time. We also know how the districts have changed their mortality from 2000 to 2017. So we understand what each district has done or not done. So we have identified, based on this, we have identified the districts that might need more attention as compared with the other districts. We have some sense of how the causes of death are different at the state level. We don't have that data at the state level, but we understand that causes of death are different at state level. And all of this now we can use to actually have more locally informed decisions, which also means better targeting of resources and interventions. So we can actually move all these rates towards 2025 target and towards 2030 target. Important messages from this. Clearly, we have made major gains in reducing child mortality in India from 2000 to 2017. And I think that's an important message to keep in mind. You know, very often than not, we still continue to talk about how high it is in 2017, which is fair. But what's also fair is that we've done very well from 2000 to 2017. Inequality in the states, within the states, have gone up. And as I said earlier, this is a good sign because it shows that the reduction is actually possible. So, for example, take an example of Bihar in a previous slide, and also of UP. So it just moves that understanding from saying that not much can be done in state A or state B. But when you look at the data across district level, so clearly things can be done at the state level within the districts. And that can then allow us to understand the barriers and facilitators within a given state. So keeping the local context in mind as to what we can learn from a district that has actually managed to have a good rate of change and reduce the rate, which we can then implement in the other districts for more actionable interventions. Sadly, 40% or so of districts may miss the NHP and the SDG targets if the current trends continue from 2000 to 2017. But what we also know is if we now have this understanding of data at district level, a focused approach in certain districts by also taking into account the causes of death and risk factor distribution, basically malnutrition here, we could aim to work towards increasing the annual rate of reduction. But at the same time, we also have to sustain the gains that we've already made. And here, COVID plays a very, what's happening with around with COVID also has larger implications on the gains that we need to sustain. I have a few slides here just to give examples of what it means in terms of actual action at that level of every woman and every child. And so this is, one is continuum of care. So the first point that I want to make here is that we need to focus on continuum of care for a pregnant woman from ANC down to postnatal care. This is the NFHS 4 data for India, where the ANC four or more visits was 47%. And this is the institutional delivery and PNC in 48 hours. But when you make an indicator for a woman who received this and this and this, it's only 33%. And this has got important implications if one were to look at nutrition of the pregnant mother, if one were to look at how you figure out high risk pregnancy, and if you were to reduce 0 to 2 days neonatal deaths, this needs to go up. So clearly, one of the indicators that we need to measure, instead of simply measuring these as standalone cross-sectional indicators, we also need this indicator that's horizontal across, and this needs to go up if our annual reduction in the rates has to increase. Here I have then expanded the definition of continuum of care to pre-pregnancy. And malnutrition, all of us know, is a big challenge. Malnutrition is the highest risk factor for child mortality. So clearly, if continuum of care before pregnancy is the nutrition needs of reproductive age women. If I extend the continuum of care on this side to until the age of 5, then clearly that the malnutrition also continues for the children here. So the idea basically is that, and of course, it's not possible tomorrow to go out and do from here to here. But I think we do need to start making effort to actually start with this and then ensure that these get in. It's also possible to do it. It's not that we have to do something new. There is maternal child tracking system. It's been established for many years now, but many of us know there are issues in terms of how it works, the quality of it. So there is something that's already there, but could be improved. Is something to think about. We still do not have uniqueness of records of patients who show up in our public system. And here I'm talking particularly of women, because every time she comes, she is another OPD patient or an inpatient when she comes for delivery. So at any given point, it's very difficult to understand what happened with this woman who comes for delivery during ANC to actually either treat her better or refer her on time to prevent mortality for her and for her baby who's yet to be born. And clearly, the malnutrition, which is a big risk factor, shows that unless it's an intersectoral collaboration, we talk about it, we know about it. But I think it's time that we see how we can actually put it in action in practice. The other indicator I want to talk about is quality of care. So one is coverage, which is what we talked about in the previous slide. The other is quality of care. So what happens when these women actually show up for a checkup? These data come from Bihar. I'm sorry if you're not able to see, these are too small for you, but this is a prospective study that we undertook in Bihar to understand what happens, what do the women get when they come for ANC checkup in a public sector facility. If one were to define quality by very simple metrics, saying that when she came, her weight was measured, blood pressure was measured, abdomen checked, she gave a urine sample for testing, a blood sample was collected, and she received iron folic acid tablets. So again, like continuum of care indicator, if I put a variable together saying a woman who got all of this, it was only 30%. So clear, and this is how it's shown. So this is by trimester. So even in second and third trimester, as you can see, the abdomen check was only nearly 65%. Weight and blood pressure measurement, which are the easiest to do, get done for most. And if an urine sample actually is the big spoiler here, a very big spoiler. And if you see this graph by wealth index, it again just reinforces the inequality that we have in our system. Then we said, okay, this is just to visit when we are talking to them. This was a prospective study. What happens to them if some of them have actually gone for another visit? So these are women who've gone for a previous visit also. So we put those two visits together, and only 8.5% of these women actually got quality of ANC as defined by getting all of these indicators in both visits. 60% of them got quality neither in the current visit nor in the previous visit. So clearly, we have gone up in the coverage. We still need to go up in the coverage, but we cannot go up in the coverage and leave quality of care behind, because that's when the mortality comes in, and morbidity for a longer term. This was to show whether women are informed of what's done to them. And this was an important indicator because in many of the large-scale national surveys and many of the household surveys that many of us undertake, we ask women to recall, okay, what was done to you? What was informed to you? Clearly, and this is prospective study, so exit interviews. So even when the blood sample or the urine sample was taken or the weight was measured, women were really not informed of the findings or what to do with that information or how to take care of themselves. The last slide on quality is about what is documented in the MCTS card of these women and in the ANC register that's kept at those public facilities. And what I've shown here is the bar showing the missingness. So after a few days, so MCTS record was seen on that day with the women, and ANC register was seen after a few days, given we gave some time to the facility to update the records. This is the extent of missingness of data in the ANC register. So which has serious implications on how do you identify a high-risk woman when you actually have such large-scale missingness of her data in ANC register. And there are similar issues around labor and delivery that we really need to take care of. Cause of death and risk factors. How do we use this data for action at local level? So what we have been saying, either from our work in Bihar and UP, primary work in Bihar and UP, there is one thing to say that we want to reduce neonatal mortality, but we do need to now start focusing on neonatal mortality. By which mortality are we talking about? That's because the risk factors for deaths in 0 to 2 days and the risk factors for deaths 3 to 27 days are actually very different. In the previous slides, I've shown you that most of the deaths are in India 0 to 6 days, but even within that 0 to 6 days, the risk factors are very different. So in 0 to 2 days, the risk factors are mostly around the delivery, the labor and delivery itself. But when you look at 3 to 27 days, these risk factors are more around illness in the neonatal period. This is when the babies go home, if they were facility deliveries, and what happens to them after they go home. And illness in that neonatal period was the risk factor accounting for this mortality, which is very clear. It correlates very well with the causes of deaths that you see. So in 0 to 2 days, 61% of the deaths were birth asphyxia, clearly highlighting what happens around delivery. But if you look at 3 to 7 days and 8 to 27 days, birth asphyxia is hardly any. It's taken over by preterm delivery and meningitis, sepsis, and pneumonia. So clearly infections when babies go home and get sick. The point of this slide is to say that if we do want the neonatal mortality rate to drop, we need to start focusing our actions based on the age of death, specifically working on risk factors and targeting the causes of death for that particular age group. This is not new to anyone. Tracking deaths and cause of death is very important across the system. And we do understand there are issues with tracking child deaths and especially neonatal deaths. But I do want to bring in this issue of punitive action for neonatal deaths as part of that audit. And unless that actually changes, that accountability of staff changes there, it's very difficult to understand what's actually happening when a baby dies in a public sector delivery. MCCD, all of us know, causes of death in India come mostly from SRS through verbal autopsies. So clearly, cause of death understanding is way more important with COVID now to understand what's actually happening and how do we prevent these deaths from happening. I've taken an example of nutrition to show how important it is to link with the other programs if we were to work on addressing child mortality. This is from the other paper that I referred to. This is a district level graph for 2017 for stunting, for wasting, and for underweight. Clear, and this is the SDG goal. So this is the number of indicators that are relevant to nutrition across the various goals that you have, the SDGs. So this clearly highlights that nutrition is one thing that is, we all know is very intersectoral, but I think it's time that we start figuring out ways to actually have that in action, in practice at that district level. Partnership with private sector. Again, many of us know why this is important and why this is needed, and which also involves not only what the private sector does, but the kind of referral that happens from a public sector delivery, from a public sector to a private sector. So clearly, many more understandings, in-depth understanding is needed to understand what happens with the private facility deliveries. This was, so Dr. Vivek Singh had forwarded this paper, again, to bring about a perspective on what happens with COVID now. And as you said in the opening remarks, so what we have presented today is before COVID, and what changes now. So this paper that got published in Lancet Global Health used the lives saved tool model here and built three different scenarios: scenario 1, scenario 2, and scenario 3, where they have different permutation combinations of what happens to these services. And if the coverage was to reduce for these services, what could be the number of additional deaths, maternal deaths, and child deaths that we could be looking at? And they have done it for many countries using the DHS data. For India, I mean, this is a very busy graph, but it shows the blue line is the baseline coverage for each of these indicators that you've seen here. And the scenario 3, which is the worst one, so the drop from blue here to yellow is the worst drop. So with those assumptions, they have assumed what would India look like, coverage for these indicators look like for India in scenario 1, 2, and 3. And based on this reduction in coverage that they projected, they then projected the increase in maternal deaths in a month in India for the different scenarios, and increase in child deaths in a given month in India for the three scenarios. Now, clearly, these are disturbing figures. And scenario 3, of course, is the worst. Having said that, I think what's important to understand, and this is my take on it, and I'd be very happy to listen to what you think of this, is that these projections are a really good value add for us to remind us that COVID is here and it's changed a lot. But the variables that go in the lives saved tool and the data that they used for coverage for India comes from NFHS 4. But if you look at, if I could go back, if you look at these variables, these detailed variables, you would see that many of these variables, data for many of these variables are actually not available for India. And these are default values that are used. So clearly, there are issues with, and that would be true for many developing country setting, but these kind of specific data are not available. But the point of this paper is very valid, that yes, we have to be wary of the fact that we might see increase in the deaths, but there is no way of us knowing what that increase is going to look like. Is it going to look like this, or is it going to look like that? That's because we know, many of us know, there is disruption. Clearly there's disruption, but we do not fully understand the extent of disruption yet. And there are implications of the disruption, yes, but what all are the implications? We understand the thematic areas of implications, but we really currently do not have the knowledge of extent of those implications. Inequities, yes, and again, death is a big question, given the cause of death in India is not available for most deaths. This was the figure that this paper used to highlight the framework for the effects of health system components and coverage of health services. So very clearly, I think anyone who looks at this figure knows that all of this needs to be addressed. My take from this paper and for COVID in general is that we have for very long, we know there are frameworks for health system. We know we have issues, for example, with health workers, but we have not treated it as a health system piece so far. We have done piecemeal approach. Our preparedness is not that great. So for me, COVID means that unless we get back to that basic of strengthening our health system the way it needs to, get everybody in, get that intersectoral, multisectoral that all of us have been talking about in, this is a disaster. Today it's COVID, tomorrow it will be someone else. So for me, this is a wake-up call to actually put these pieces in place the way they need to be placed, so that we are well prepared for another event tomorrow. Thank you. Questions? I hope I'm able to see you. Hello.
Thank you so much. I think Vivek, are you coming in here?
Yes, good afternoon, and sorry, I was trying to find the unmute button. Thank you, Dr. Rakhi, for this presentation and also taking the time to reflect on the second paper which came out recently on the COVID-19 impact. This is very useful, and while some of our colleagues, they warm up for a few questions that we have time for, two or three things which are very clear from the work that the group has done. One is we see that you have these working groups, which is very heartening to see that there is this GBD group on the maternal and child health issues. I noticed there's one on nutrition, which is slightly worded differently if I forget that slide. But
yeah,
there is
the dietary risk group, yes.
Yes, the dietary risk group.
Yes.
And I see another group which is very relevant to some of the work that we do, especially for the most challenged population groups in some of the challenging systems in the states, which is around malaria and other issues, for example, AES. So I saw 3 or 4 groups which are very relevant to our work, and you'll see more of our colleagues, especially Ajay from the knowledge management group, he leads that, reaching out to you. To see how the work of these groups and we can find more complementarity working together with these groups.
Fantastic. And even your first comment clearly is highlighted how everything is so connected. Even though we do have these separate groups to work on the details, but everything is so well connected. Yeah, thanks. Look forward.
And the second point before we open to the questions is that when you see health and nutrition, traditionally, in fact, within UNICEF, health and nutrition was one section. So health was never disjoined from nutrition. It's just that the burden of work that these two streams now have. So within UNICEF also, they had to separate because of the mandate, which became so large when we started looking at these two issues, that we have two separate sections and equal amount of colleagues, workforce that we have on the ground. But your work, your group's work really points to the fact that these are two issues which cannot be separated. And when you especially pointing out about the continuum of care and how two major risk factors are around the maternal malnutrition and the malnutrition among children. So that is another area where we would want to keep connected to these groups who are looking at these things holistically. Now, for a few questions, I see one of the questions, I want to give the floor to Apurva if she's listening. She has a question regarding some of the issues which you raised around 0 to 2 days kids and around maternal mortality also. Apurva, can you hear us?
Hello.
Yes, please ask your question. I saw your question around 0 to 2 days deaths, and you had some questions, please.
Yeah, my internet is little troublesome, so I'm not sure if I'm loud and clear. Am I audible?
Yes, you are.
Yeah. Thank you, Dr. Rakhi. It's a real pleasure to hear you live and especially to read your paper and then get a deep perspective of neonatal mortality in under 5. So my question was that we do not have district level estimates for maternal mortality, and in your study you have already prioritized the districts for neonatal mortality rate. And considering that most of the neonatal deaths in one of your slides where you presented the focus by age of death around 0 to 2 days and 3 to 7 days, this is also the period where maternal deaths and stillbirths coincide. So can we assume that these are also the districts to focus on for maternal mortality reduction, or is that a wrong assumption from the scientific perspective? So one was that, and there was second question which I would like to ask right now. The second paper by Timothy, the global series, it talks about 4 critical interventions. One is uterotonics, anticonvulsant, antibiotics, and clean environment. And the paper says that these 4 will contribute to around 60% of additional maternal deaths due to indirect effect of COVID. Now, these interventions are mostly observation based if you want to track these and see their coverage. So how do we monitor coverage of such kind of interventions, especially during COVID times when HMIS is unpredictable and has limitations, and visit to the facilities, physical observation is difficult. So coverage of childbirth interventions, how do we monitor these? Over.
Thank you.
Thank you.
Thank you. I think both the questions are really important questions. I would just take you back to that slide that you had referred to. I think I have to start sharing the screen again, is it? No, I can't. Can I please share my screen? There's someone else sharing at this time.
No, you can please go ahead and share, Professor.
Yeah, I think
I
someone
think
else
Ryan
is
is sharing his screen for some reason.
Yeah, someone else is. Great, thank you.
Okay, good.
Thank you. Right. All right. So this is the slide, Apurva, that you were referring to, and thank you for this question on stillbirths. I will take that first, and then the maternal deaths. You know, we when we talk about child mortality, and let's say neonatal mortality in particular, we forget the stillborn babies, and thank you for that reminder, because if you look at the risk factors here on this slide, the 0 to 2 days risk factors for neonatal deaths, these are mostly the same risk factors for stillbirths.
Yep.
These are actually not very different. And as you know, the stillbirth from, if you look at SRS, is hugely underreported in our country, and for a very long time. And it's also it's a mixed reporting in HMIS, because that also has accountability issues from, you do not want to show a 0-day death. It's easier to show it as stillbirth so that you're less accountable. There are various issues around that. But the recent work that we did in Bihar and also in UP at population level, for the first time actually brought out population level estimates for stillbirth at state level. And Bihar was close to 20 as compared with 4 that gets reported in SRS. So you've raised a very important issue. Yes, when we talk about neonatal deaths, we cannot ignore stillbirths, because at least half of these are intrapartum stillbirths. And the other important point that was raised with Bihar work of stillbirths was that many of these are also due to the skills and capacity of health workers or the health providers that are doing delivery at that point in time, and had those skills and capacities been better, that baby could have been born alive. So we've done that kind of analysis. I'm happy to share that paper, but thank you very much for raising stillbirths within that child mortality framework. Maternal deaths, yes, is as you know, is very tricky. We have data at state level. I'm inclined to say that the high priority districts for neonatal mortality could also be high priority districts for maternal deaths. Having said that, one of the other important things for maternal deaths is also where they deliver. In terms of private facility, public facility, or home. And referral and complicated deliveries, understanding of that is also important to know what's happened with, what could happen with maternal deaths, which may not all of that may be that relevant as much for certain types of neonatal deaths. So I'm inclined to say yes, but I do not have supportive data beyond the logic that you have also used. And linking this to your next question about how do you monitor the interventions that are currently in place given the COVID is happening, which is also true otherwise. We are very poor at understanding the clinical part of interventions in the country. HMIS does not really allow us to do that because our medical records are very poor. We do not have medical records that actually document enough clinical data for us to understand which kind of delivery is actually likely to result either in a maternal death or in a neonatal death. So unfortunately, what we are going to see right now would also be assumptions and our experience at the ground level, as all of you talk with what's happening at ground level, start to see what is happening, but we do not have solid data that can actually tell us what's changed. So again, as I said, as we start to strengthen our health system to be prepared for all this, we cannot ignore medical records. And that's true not for maternal child health, that's true for anything in general, but maternal child health in particular, as we're talking about it. Unless we get to that clinical data beyond a point, we will not be able to reduce the neonatal mortality because we have no idea that this woman was high risk factor because she had syphilis, she had malaria, she had HIV, she had diabetes. We have no sense of that in HMIS, unfortunately. Utrotronics is an important issue again you raised. At population level, it's very difficult to understand that. And within HMIS also it's very difficult, but again with the medical records, when you do put in medical records or registers in place, from my understanding of what I've seen in Bihar and UP is that when many women actually come with these injections before they report for facility to a facility for delivery, it's a very tricky situation to understand what's actually happening with these. So some ethnographic work is going on with utrotronics in Bihar, and I'm happy to come back to you with those details once we have more information. But that's all I can offer right now.
Thank you so much.
Thank you, Dr. Rakhi. And I think some very valid questions from Apurva, and especially the fact which you raised moving forward nationally on strengthening of health systems and what we've learned from this pandemic. So many of our colleagues who are directly working in the response also realized this, that as government had reached around 20,000 plus cases, it was realized that the case investigation form needs to be complete. And actually it was an exercise in retrospect at around 20,000 numbers that the case investigation forms were being completed for the health information portal. And from there on, it was decided that the medical records should have at least the basic minimum information which is required for any epidemiologic analysis moving forward. So with that, I have two more questions, and it is Professor Asheper, who also leads a maternal health portfolio at the team, and then IC Chief. So Luigi with the next question. So over to Asheper, please, and then Luigi after that question, please. Prof, can you hear us?
Thank you, Vivek, and thank you very much, Professor Dandona, really for that very rich and very practical study and presentation. Not to say that I have any questions on the presentation, it's just that for all of us to digest what we have learned and see how to use it in our practice. But looking at the study, I felt that a little bit more of addition to the study could really make this study very transformative. Because I am seeing that you have the list of the districts, 2000 year 2000 rates of child mortality and newborn mortality, year 2017 district level newborn mortality, data, trends, and some contributory factors. But if we have this data, can't we generate district level data for social determinants, social sector determinants, as well as health level determinants? I'm sure this additional step, we can generate tens or even hundreds of this district data. Then this can really empower the study to have an ecological study to see what are the contributions of these various factors that to this change. I see only nutrition. I clearly see the impact of nutrition, but there are many other factors, both in health system as well as outside the health system, that could go into an ecological model without much additional added, but really make the study transformative. So that was just my question or a comment. Thank you.
I think that's a very, very important point. Clearly, if those kind of data were available, that would be the really next big step. We do try to account for some of this using the social the development index that we use, but of course, I mean there are many more other variables that can go into this. Also that data at district level for variety is not readily available. But yes, the point that you've made is very valid, and it's actually on our list to see if we can move forward in that direction. So thank you very much.
Thank you for your comments. Hello.
Yes.
So for our next question, over to you, Chief.
Yes, actually, my comment is not very scientific, but pretty much pragmatic. And maybe before that, really, this paper is a manifesto of our work. In UNICEF, it spoke coverage, quality, multi-sectoral interventions. It spoke to prevention. So it's really, thank you so much for spending some time with us today. My question is very simple. I just wanted to know whether you had a chance to overlay your mapping with the aspirational districts that the government of India has defined. The reason for the question is very straightforward. I think we know as a fact that most of these districts with the worst indicators systematically have the lowest per capita investment in health expenditure. They have the highest gaps in human resources for health and probably the lowest socioeconomic indicators for the population. So I'm looking at the aspirational district as the platform that can really help a sustained investment at district level. And if that is the platform identified by the government of India, I wanted to know whether this is done already or what it would take to overlay one with the other, because then as you work out the ecological model together with Prof. Sheber, in the short term, we would have an immediate platform to advocate with the government of India on this data, as well as on the investment they are keen to make through the aspirational district program. Over.
Great, thank you for that question. So yes, we have done the overlap of the priority districts that we identified. Actually, not the priority districts. So what we've done is, so all the districts, 723 districts are cut across those strata of high, medium, low. And we have done that overlay to understand how many of the, let's say in the high rate, if you look at under 5 mortality, high rate districts with low rate of change, there are about 76 districts in India of the 723. Of these 76 districts, only 26 are shown as aspirational districts. So only about 34% of the districts that we identified showed up in aspirational districts. To say that, so we have identified more districts than what is there in aspirational districts, and I'm very happy to share that very specific data for action at your end. So certainly do that.
Thank you, that would help. Probably this comes from the fact that the aspirational districts, of course, were identified on the basis of broader socioeconomic SDGs indicators. But if you could share that, that would be an interesting exercise for us. As you were speaking, I have a second question, if Vivek allows me.
Please, Chief.
Just recalling back to your presentation, your modeling against 2025 and 2030 was assuming a stable rate of change in the mortality trends.
The
now
trend
again,
so the trend from 2010 to 2017.
Yes. Now again, my question is, did you have a chance to model different trends, considering the fact that when you reach, I mean, just to make it very simple, to move from 10% coverage to 20 takes a certain level of effort. But to move from 80 to 90, it's a completely different game. And the same applies when it comes to reducing mortality. So did you have a chance to model how that picture would look like if the trends were not linear?
That wasn't done as part of this exercise, but because the way this model runs is it learns from the trend from, let's say here it learned from 2000 to 2017, and we assume that that continues and this were to happen. There are a lot of permutation combinations that could change that, but that's a good point. We really haven't tried it. We did attempt a little bit of it, not as that detailed for some of our UP work, but not to the extent that you are referring to. But that's we will continue to explore and see if what that can tell us and how we can do it. So certainly on our list, and we'll keep you updated with that.
Thank you so much.
Thank you for these very pertinent questions. And while I still wait for one more question, maybe from the colleagues as they warm up, I have a couple of questions or other comments based on some of the things that you said, Dr. Rakhi. And one of the question is, you mentioned about a paper almost similarly timed released by the group on child growth failure.
Yes.
So if you can mention a bit about that paper. And the second thing is, I think the most important pointer based on the question that Luigi had, and then what you mentioned on your last slide, was now trying to understand the barriers and facilitators for these different groupings that you have made with these tertiles. So for example, why certain districts? What were the barriers and facilitators for the group of districts which are high with high rate, vis-a-vis which were high with low rate? So I think that's the level of inquiry which should take us to the next level of transformative translational value, which Professor Echeber has said. That once we start, those maps are very useful when you projected the UP maps, giving those tertiles and those 6 groups. But as you also said, that now for us to understand what were the barriers and facilitators for those districts to be in those groups, and how can some of the groups, for example, which are high with very high rate of decline, learn from the others. So that is going to be the next inquiry where our teams would also be interested. The second is this child growth failure, if you can show more light on that, please.
Sure. I have a couple of slides from that paper. Maybe I can show that. I just had one slide in my presentation, but I can just share that with you now. Can you see it?
Yes, please.
Oh, wonderful. So this paper basically talked about stunting, wasting, and undernutrition. So similar, logic was that we understand it at state level, but we do need to start getting down to district level, even with child growth failure. And so this is the stunting in 2000, and the way it is now in 2017. At district level, it varied by 4 folds, so ranging from 16 to 63. And the best part was it declined almost everywhere. So you see it declined in 99% the prevalence, but the decline was very varied, but also since 2000. So clearly a lot has happened even at this level, but more needs to be done. This is same logic of identifying the priority districts for stunting, and this is how it looks. A similar thing was done with wasting. So what we could do is, so basically similar logic to get data down to a district level. So basically shows that we've improved from 2000 to 2017, but clearly more needs to be done. So I think as an immediate utility to your group, given that you do health and nutrition, I'm just thinking aloud. Maybe what we could do is we could put together a set for you to that overlaps the districts, and that allows you to have that understanding of what the child mortality indicator for that district is and what are these nutrition indicators for that district, and how these are different based on priority if you look at only mortality and if you look at only those nutrition indicators. I think that would be a good actionable item for you to start thinking as to how you approach different districts. We can certainly do that. But
That'll be really useful.
Is similar. Yeah, we'll do that.
That'll be really useful, and we are really grateful for that if we can have that. So that saves me a question that your paper mentions that the list of districts are part of some other papers which are mentioned in the bibliography or as annexures. So is that available, the list of districts in the different groupings in some of the bibliography mentioned or the annexures submitted to the journal?
Yes, so the annexure is also available online, and I can actually circulate the paper and the annexure to you. And the maps that I showed for UP and Bihar in detail, those maps are available for many other states. That detailed district maps are available for many other states in that annexure.
So if you can share that, that will be useful. So before I pass it on to Ajay, I also pick up one of the other points which Luigi mentioned, that thanks for sharing your other studies where you have highlighted that when we think of the UHC cube, that it's not just about all the services being available to everyone, but what is the range of services. So I like the word when you use content and quality both, that when a pregnant woman is coming, what is it that she's getting in terms of the range of services, and then the quality itself. Yeah. So quality, content, and as you said, continuum of care and convergence between health and nutrition, all this needs to come together for the mortality reduction for under 5 and newborns. So that is something which we also, it resonates very well. We have picked that. And you will see more of us reaching out, and especially Ajay, to collaborate with your team for all the good work that you are doing. So with this, unless I miss someone in the questions, I see
yes,
one.
There's a question in the, there's 2 questions, Vivek, in the chat box.
Yes, so I see 2 more questions, and I think there's a question from Salima and then Mainak. So Salima, can you hear us?
Yes, very much. Am I audible?
Yes.
Yes.
Salima.
Hello. Thank you for a very, very detailed presentation. I just wanted to understand that, there have been a lot of questions around the average weight gain during pregnancy, and then the weight gain during pregnancy and its impact on low birth weight or birth weight. So can the study throw any light on these 2 aspects? Is that a possibility? Thank you.
That's a fantastic question, and I think many of us are dealing with that as we try to understand low birth weight better. But no, this study cannot do that because this is not at that individual level. And the weight gain data, as you know, is not readily available during pregnancy. It's actually not readily available. So unfortunately, no. But what I can still tell you is from our work in Bihar and UP, in particular in Bihar, the ANC work that I was talking about, perspective, because there is so much missingness of the data. So even when the weight is checked, if it's not written in the MCTS card, or if it's not entered in the ANC register, or if the ANC register is not unique, so there is no uniqueness of the woman. So if she comes the next time, you have no idea what her weight was the previous time, right? Because you simply write it as a line for every woman. The way we are having data within the public system, it is very difficult to comment on the weight gain that happens over pregnancy for these women. Very, very difficult. Point number 1. So again, it brings us back to, unless we record everything every time and it's uniquely recorded, so someone can actually look back. So even on the MCTS, the card that they have, it's basically empty. So one is writing it and one then is using it. So clearly there are big issues with that. Birth weight is a similar story, but the important point in birth weight is when you look at birth weight availability in surveys, when you ask women, what was the birth weight of the baby, more often than not, you find that babies who had died and those who had died on 0 day of birth, the weight availability for them and the babies who were delivered at home is actually very low. So what it tells me for the system is that if the baby is dying immediately in a few hours, we are not even recording the birth weight because the baby is dead. But that defeats the purpose because then we do not understand if these babies who have died, were they more likely to have low birth weight? So this is the practicality of it. So birth weight at that health provider, A&M, nurse level, the understanding has to be the birth weight has to be measured irrespective, whether it's a stillborn baby, whether it's a baby who was born alive and died immediately, and of course, home deliveries, the birth weight has to be measured. But this study doesn't tell us much. Sorry.
Thank you.
Thank you very much. Mainak, do you still have?
Yeah, thanks for the opportunity. Thanks, Professor, for your presentation. I just had a very small point of clarification for myself, if it's possible. So when I was looking at the district level variations, would you primarily ascribe them to input inequities? Because as we know, NHM has been in existence for so many years, and sort of the training, capacity building, resource inputs that have gone into the system for addressing these interventions, and the interventions themselves are pretty well laid out. So would you ascribe them primarily to input deficiencies or inequities, or would they be primarily process deficiencies or differences between various districts which are giving rise to these inequities? And the follow-up question would be, does it make sense for us as programmers to look at process deficiencies or process efficiencies more than what the intervention should be? Thank you.
Again, a fantastic question. I wish this was a face-to-face, meeting, and we could have gone. Again, fantastic questions. Yeah. So to answer your first question, all that you said, yes, is responsible, but it's the input to begin with, the deficiency in the system, and the processes across. But this data does not allow us to understand that. So this is why we need to get down to the district level, have that understanding at local level to see what could be different. And I'll give you one example. Just give me a minute. I'm looking at that slide. I'll give you one example to highlight the process issue that you've talked about. Birth weight was one example just now that I gave about it, but I do want to give another example which fits very well with UNICEF's work. Just give me a minute. So this is, I will show you a process so one of the other works that UNICEF, one of the important work that UNICEF does is around the registration of births and deaths. And that's one extensive work that you do. I'm going to share this slide. Which is a very good example of how the processes can be, if you don't define a process, it's as good as not having a system in place. So in UP, and can you see the screen? Yeah, can you see it?
Yes.
Right. So this is a process mapping of a birth registration in Bihar and UP. And I just want to highlight the point on process here, that one is to put a system in place and one is to put a process in place that everybody understands and is standardized. I'll simply give you this example here of a birth at public facility, and because UNICEF does work in birth and death registrations. If there's a birth at public facility, The government has made the system that it should be automatically registered in the civil registration system, right? So the notification and registration happens. So at least we know that there has been a birth, and similarly, there has been a death at the facility. But at the process level, what happens is, and all the data comes to this data entry operator. He enters it in the CRVS portal, but he does not submit the data. He saves it. He submits the data only if a family shows up and says, look, we want a birth certificate, right? So clearly highlighting that even though government put a system in place that at least all the public facility deliveries, births in Bihar and UP could simply be updated, uploaded in the system, but the process at the end was they still assumed that unless the family wants a registration certificate, there is no point uploading the data. So clearly, processes are a big challenge, and we haven't invested. From whatever I've seen in maternal child health and in CRVS, we really haven't invested in putting the process in place or standardizing the process in place.
Thank you, Dr. Rakhi. I think
thank you so much.
These were great inputs. And one thing before I hand it over to Prof. Esheber to guide us how we should make sure that we continue this journey for more translational value of all the good work that your team is doing. So one thing which I have clearly picked up is that we have our biggest teams, of course, quite understandably in UP and Bihar. So maybe I can already think of the next talks maybe can be led by Dr. Kanupriya, who leads our UP portfolio, and Dr. Ali, Hube Ali, who's in Bihar, to help our teams in UP and Bihar, and also the state governments benefit more from all that work collectively that your team is doing for UP and Bihar. So maybe those are two sessions we'll seek your time, where we can also engage with the state governments to make sure that we use some of your work. So with this, I would hand over to Professor Esheber to actually help us understand that how we take this work forward, especially around understanding, as you said, these facilitators and barriers now in those different set of districts to make it more transformative. So with this, I hand it over to Professor. Prof, can you hear me?
Thank you very much, Vivek. And really to thank again, once again, Professor Dandona for this and the entire collaborative. You know, this is a huge work, of course, and I understand it's a huge collaboration behind it, but to really thank her for her time and for this huge study. As Luigi has said, and you have also indicated that looking at these slides, you know, there isn't a single slide within this presentation which is theoretical for me. Each slide can be immediately taken and used for utility to improve the lives of mothers and children at many levels. That is two things, you know, it's so rich and it's so practical. Two, it clearly tells us where we are. A lot of progress has been made. The direction is very clear. A trend in such a socio-economic variable like newborn mortality and child mortality is a social trend. So it is likely to continue. Whatever is causing it will not stop. So it will continue. Of course, we have COVID. Hopefully, it's a temporary challenge along the way. But the dynamics, you know, the trend is very clear. While looking at the trend, also the actual numbers are still disturbing. I mean, 1 million children dying every year and 500,000 newborn dying every year is not a small number, and it doesn't become also the country now, the 2020 India. I mean, the 2020 India is the 5th largest economy. It's a land of science. It's a land of academia. It doesn't become, something doesn't sink. So this is something that the country needs to improve. And of course, that is also the crux of the global SDGs. As you know, one country which needs to achieve for the global SDG to be achieved is India.
That's right.
That is clear. So, and then it really tells us where we are, you know, with regard to the SDGs, with regard to the national health policy targets. We are very clear where we are and how much we need to accelerate. in terms of annual reduction if we need to achieve. For me, the first new thing that this study has given me is a view on equity. Definitely, when we look at equity, we have the urban-rural equity, which we always know, we always look at. But this is the issue of a bit of dimension to geographic equity, which this study has added, is the political dimension, because borders are not scientific issues. Country borders or state borders or district borders are not scientific. They are political issues, but they do determine services. So really, having adding a geographic lens to equity is very important. And this study, I think, has really presented that. As Professor has said, the granularity needs to be increased because district is a big social demographic entity in India. There is a district with 11 million people as per the last census. And the average districts are 2-3 million. So, of course, the granularity, as you said, has increased, but things will happen with steps. So this study will initiate the additional, block level and other granularities that will go. But a huge leap for our program. And as Apurva has asked, she has already asked for maternal mortality, but let's take it, at least we have for under 5 mortality. And then we have for newborn. And then with that, after some time, we'll ask also for maternal mortality. It's not so easy in terms of the numbers. The statistics is a bit challenging, but this is a huge leap for our mortality. I can't really express to you. Now, the ecological studies, you see, in addition to being health indicators, infant mortality, child mortality, and so on, are also socio-economic indicators. They are determined by huge decisions that are made in economics, social sector, political sector, and so on. So, and two, I think the huge part of the study has already been done. And a lot of district level studies from the WASH sector, from the economic sector, from the nutrition sector, from the agricultural sector, from the private sector, from the income, GDP, a lot of studies can be generated, I think, without the need to have to go to the district. But those additional variables generated, at the center, we can do an ecological study. But those inputs can impact huge policy decisions, particularly at socioeconomic, where to invest, for example. Is it better to invest at individual level or at family level or at macroeconomic level? These decisions are always argued. So this study, beyond what it is practically already going to help us, and that is ready for us, it can impact also those decisions, major decisions, because of the value of these indicators as being determinants of socio-economic progress in large. And we also in the health sector feel that those decisions are really impacting. It's not just because 70-80% of all health improvement is outside health. It's beyond doctors, it's beyond nurses, it's beyond hospitals, it's beyond whatever we call healthcare. About 70% of health improvement in general. It is within outside the health sector. It's in education, it's in nutrition, it's in economic progress and so on. So if we can add those variables, have a larger ecological study, and look at, for example, how much of private sector investment has led to, so in those districts that showed the highest rate of progress, what was the contribution of the private, the major contributors, what were they? And in those districts that did not perform, what were the major contributors in terms of government investment, private investment, and other things? For example, India has made a huge WASH intervention. Was that a huge contribution as compared to education, as compared to, so a 17 years trend is a huge trend. If that is added, I think it will lead to huge values. But as far as UNICEF is concerned, we are almost already, it is already a huge input for us in our aspirational districts that we are supporting, but more importantly across the country in the 23 states that we are supporting. So really to thank you very much, and also I would like to thank Luigi and Vivek and all others who have really made this presentation possible, coming to you and making you make us to have this interaction. I really thank them very much, and the team for attending, and also for many of these dynamic questions that were in the discussions that followed. I really thank them. So these are my inputs, but I look forward also to inputs from Luigi and Vivek on how we can take this forward also. Thank you very much.
Thank you.
Thank you, Professor Randona, and that was really thank you for putting together a very rich and a powerful presentation, which was definitely, I can share, many of us, it was music to the ears, because this is what the data is now showing. I'll be in touch with you and your team to further take down for taking this workshop to states like UP and Bihar, and look at other topics which can be taken up in terms of replicating a similar a granular look at the data of the bigger states. Thanks a lot again, and we are well within the time period, and I hope you enjoyed as much as we did as a team. Thanks a lot.
Thank you very much. I did, and and thank you for reaching out again. This has been really great, and you have given me a lot of food for thought. I will clearly come back to you with all that I've promised. But thank you for giving us more ideas to refine and look at things in a different way. Looking forward to a more active, continued collaboration from now on. Thank you very much.
And Professor Luigi here, just a couple of final words. First of all, allow us please some time to digest all the information that we were exposed to today, and then we will come back with, I'm sure the team will come back with more questions or ideas. The second is that as we keep digesting and thinking of ideas, let me put it forward that for sure at some point towards the end of June, regretfully again, it will be virtual, but we will have what we call an entire meeting of the health team across India of UNICEF. And at some point, we are also coming together with our nutrition team. So I will talk to my colleagues, but it would be very nice if you could join us during our annual meeting. It will be strange because we have never done before in life an annual virtual meeting, but if you could join us, and we would of course discuss how to best tailor the session at that point. And the very last point, I mean, this opens up a lot of thinking and also a lot of opportunities for further collaboration. So be it some mixed methods, small scale qualitative study, or like mixed studies to deep dive into some green and red districts and see what were the key social determinants might be a way forward, acknowledging that maybe taking a decade to map out all the socioeconomic determinants across 738 districts, which is the dream that Asheber very well laid out. But there are many things we can initiate a dialogue on. So we will reach out and see how we can best make use of this just as a starting point for more dialogue going forward. Thank you so much again.
Thank you. Thank you. Looking forward to that. Thank you.
Thank you, everyone.
Bye.
Thank you. Bye. Bye.
Bye. Bye.
Bye.